Hello everyone, welcome to this short tutorial from Pathology made simple at ilovepathology.com. This is in continuation with the diseases of the breast series. In the earlier parts, we had discussed about the breast cancer, its risk factors, etiopathogenesis, pathology, classification, and about carcinoma in situ. In this part of the breast cancer series, I will be talking about the invasive duct carcinoma, the special types of breast carcinoma, how the breast carcinoma spreads, what are all the various prognostic factors, and finally a bit about the treatment of breast carcinoma. So let's begin with invasive carcinomas. In the last part, we had talked about the non-invasive carcinoma, that is in detail about the carcinoma in situ, that is DCIS, lobular carcinoma in situ, and a bit about Paget's disease, right? So today we will be discussing in detail about invasive carcinoma. Invasive carcinoma are categorized into two broad types. One, all carcinomas that are of not a special type, and second category is a special types of invasive carcinomas. So the first one, which is of a not a special type, is basically referred to as invasive carcinoma NOS type, which is a typical ductal carcinoma. This accounts for the majority of cases of invasive carcinoma. 70 to 80% of cases are of this type. The special type includes all other carcinomas like lobular carcinoma, mucinous carcinoma, tubular carcinoma, and so many other types which I'll be discussing in detail a bit later. You can see that there is a carcinoma with medullary features. This was earlier included in special type, but now in the recent 2019 WHO classification of tumors of breast, this is a part of, subset of this invasive carcinoma NOS type. This is another end of spectrum of invasive carcinoma NOS type. We'll be discussing this in detail shortly. Now, what is the pathology of infiltrating duct carcinoma? No special type. This is the most common type of breast carcinoma. The precursor lesion is ductal carcinoma in situ. The clinical features, they present as a palpable mass, usually with retraction of nipple, with or without palpable axillary lymph node metastasis. Mammographically, these are seen as radiodense lesions with or without microcalcifications. This is the clinical manifestation of invasive duct carcinoma. So with the underlying carcinoma, what you usually see is the retraction of the nipple. Very characteristic feature, retraction of nipple. Sometimes you can find the overlying skin is thick and pitted, and this appearance is classically referred to as POD orange because it resembles that of an onion scheel or orange skin-like appearance. Sometimes in the case of extensive diseases, the overlying skin can also be involved. The ulceration can be seen in the metastatic depth side, that is axillary lymph nodes. So this can be very advanced stage where you can find extensive ulceration of the overlying skin and huge tumor size. On cut surface, you can easily make out that the invasive carcinoma is solid gray white mass with an irregular stellate outlines and infiltrative borders, and this is how it looks like that of a crab. That's why it's called crab-like appearance, and it has a typical cut section feel, gritty cut surface, and the adjacent parenchyma, what you see here, is unremarkable. Now, microscopically, you can find areas of DCIS, which is a precursor lesion, and this is a foci of invasive breast cancer. So what you see there, you can find pleomorphic cells which can form tubules, which can be in the form of clusters or sheets. These are having highly pleomorphic nuclei with prominent nucleoli. Can you make out the stroma surrounding it? That is fibroblastic stroma. It's referred to as desmoplasia. So the illustration of a microscopic feature, look at these pleomorphic tumor cells arranged in tubular pattern. You can find variable infiltration of tumor cells in the form of clusters and nests. Abnormal mitosis you can see, and the typical desmoplastic stroma. And because of this predominant desmoplasia, this was referred to as serous carcinoma as well earlier. Now, how do you grade these tumors? The grading is done by using modified Bloom-Richardson grading system. It's also referred to as a Nottingham grading system. It's based on three components. One, tubule formation, how much tubules are formed in the tumor, what is the amount of nuclear pleomorphism, how many mitotic counts you see. Okay, each of the above parameters are given a score of 1 to 3 with a final cumulative score of maximum 9. Based on this, the carcinomas are graded into grade 1, grade 2 and grade 3. Grade 1 is a well differentiated carcinoma, grade 2 is moderately differentiated, and grade 3 is poorly differentiated carcinoma. You can find evidence of calcification and or necrosis. Now, what are the features of these grades? In the grade 1 tumor, the tumors predominantly grow in a tubular pattern or a cribriform pattern. They have a very small uniform nuclei and has a low proliferative rate. The mitotic index will be very low. Whereas grade 2 tumors, they grow as solid clusters or single infiltrating cells. They show a greater nuclear pleomorphism and also have a high number of mitotic figures. Grade 3 tumors, they invade as ragged nests or solid sheets. They have a marked nuclear pleomorphism and extremely high proliferative rate with evidence of necrosis. So this is how grade 1, 2 and 3 tumors look like. Now moving on to the next carcinoma, which was earlier referred to as a special carcinoma, that is medullary carcinoma, but now in the 2019, the latest WHO classification of tumors, the medullary carcinoma or carcinoma with medullary features is no longer a separate entity, and now it is renamed or subset of an infiltrated rectal carcinoma, NOS type. It's called invasive breast carcinoma, not special type with medullary pattern. Over half of BRCA1 associated carcinomas have this appearance. What happens here is that there is down regulation of BRCA1 expression. That's because of hypermethylation of BRCA1 promoter. So this particular down regulation is observed in 67% of these tumors. Usually they are found in younger age group than that of regular invasive ductal carcinoma, NOS type. The mean age is around 45 to 54 years. They present as a well circumscribed mass, mimics a benign lesion. So whenever you come across a case of a well circumscribed mobile looking mass in a middle-aged female, think about medullary carcinoma. It could be malignancy and not fibroadenoma, which is actually a common benign lesion. So sometimes it may present as a rapidly growing mass. Lymph node metastases are very infrequent in these tumors. Now it does not produce desmoplasia, so that's why it's more yielding on palpation, even on cut section, than typical breast carcinomas. The tumor is very soft, pale grey and fleshy, and that's why it was earlier called as medullary carcinoma. Medulla means a center of a tissue. It's a Latin word for marrow. These are, as I told you, well circumscribed lesions. Can you see this? This is a well circumscribed grey-white lesion. Unlike infiltrating carcinoma, NOS type, where you saw was typically irregular infiltrative borders. So this is a gross appearance of a medullary carcinoma. Look at this, a well circumscribed grey-white lesion. So microscopically, the diagnostic criteria is very important. There are criteria. These criteria has to be strictly met. What are those criteria? Syncytial. The first one is syncytial growth pattern in more than 75% of the tumor. Now, what do you mean by syncytium? Which means a mass of cytoplasm due to the fusion of cells resulting in multinucleation. Syn means together, united. Cyte is cell, and syncytium means they look like sheets of cells. So this is a syncytium of the tumor cells here. Now, what is another characteristic feature is intense lymphoplasmacytic infiltrate in the stroma. You can make out all these blue dots are lymphoplasmacytic infiltrate, and the borders are non-infiltrating. Unlike in a regular invasive carcinoma, this is non-infiltrating. It's also referred to as pushing tumor border, and that results in complete histologic circumscription. You have highly atypical tumor cells. The nuclear features are very predominant. They are pleomorphic nuclei, moderate to marked nuclear pleomorphism. But remember, there will be no glandular structures or no tubular structures. So this is a higher magnification. You can make out that it's a syncytium of cells with moderate to marked pleomorphism, and then you find lymphoplasmacytic infiltrate. Okay, so that's how a hypomagnification of invasive ductal carcinoma with medullary features look like. Now, intense lymphocytic infiltrate, I told you, right? That reflects an active host response to the tumor. It accounts for its favorable prognosis. Now, that's why these tumors, just represent one end of spectrum, the other end of spectrum of tumor infiltrating rich lymphocyte, invasive breast cancers of not special type. Now we will move on to the special types of invasive carcinoma. They can also be organized into molecular groups based on expression of ER, HER2 as that of other breast cancers. We'll talk about it a bit later. Now these tumors, that is special tumors, they often harbor unique genetic aberrations. They have a distinct gene signatures, and the clinical features and prognosis are unlike that of carcinoma of regular NOS type. They are a special type of tumors. The first one is a lobular carcinoma. Now we saw the lobular carcinoma in situ, right? There also there is an E-cadherin gene mutation. Okay, here also there will be biallelic loss of expression of CDH1. This is the gene that encodes E-cadherin, similar to what we saw in LCIS. So on histologically, these tumor cells, just like LCS, these are also discohesive but invasive. They characteristically grow in a single file pattern. Look at this, one cell behind the another. So this is a characteristic feature of a lobular carcinoma, and some cells, they may exhibit signet ring like morphology, no duct formation whatsoever, because we know that there is lack of E-cadherin. Because of lack of E-cadherin, the cells cannot attach to one another, and that's the reason why there is no possibility of formation of duct formation. Now these tumors, lobular carcinomas, have a very distinctive patterns of metastatic spread. They involve peritoneum and retroperitoneum. They can involve leptomeninges, and when they are involved, it's called carcinomatous meningitis. They can involve gastrointestinal tract. They can involve ovaries and uterus. Now let's move on to understand the other types of breast carcinoma. For this, let us see the molecular profiling or molecular classification. Initially, in the earlier tutorial, I talked about these three types, right? The luminal cancers, HER2 cancers, and triple negative cancers. Now, what are all the special types of cancers which comes under luminal cancers? They are lobular carcinoma, as we discussed. Mucinous carcinoma is a type of carcinoma where you find extensive extracellular mucin. Tubular carcinoma, predominantly the malignant cells are in the form of tubules. Papillary carcinoma, you have a very beautiful papillae with fibrovascular core. All these are under luminal cancers. These are all cancers with rich ER positive cells. The second one, HER2 cancers, apocrine carcinoma and micropapillary carcinoma. These two come under HER2 cancers. Okay, they have HER2 overexpression. Apocrine carcinoma because the tumor cells are having abundant rich eosinophilic granular cytoplasm. They are called apocrine cells. Micropapillary is a misnomer. They look like a bulbous protrusion. This is what we saw in one of the types of DCIS, right? Micropapillary DCIS. So the invasive part is a micropapillary carcinoma. The triple negative breast cancers, TNBCs, all the three markers are negative. These are metaplastic carcinomas, the secretory carcinoma, and the one what we studied, invasive breast carcinoma, not special type with medullary pattern. These can be triple negative breast cancers. Now, having known the types of breast cancers, both not special type and the special types, let us see how the breast carcinoma spreads. They can spread either directly by lymphatics or by hematogenous. Direct spread means into the skin, including the nipple and areola, can sometimes penetrate into the chest wall as well. Lymphatics can be axillary, internal mammary, and supraclavicular lymph nodes. Hematogenous spreads can be to the lungs, liver, brain, and bone. Now, after knowing how they spread, let us see what are all the prognostic and predictive factors of breast cancers. Now, there are two terms, prognostic and predictive. What do these two terms mean? Prognostic means they are important in counseling patients, about the likely outcome of their disease, how to choose the most appropriate treatment, how to design the clinical trials and all those things. Whereas predictive factors means they help to determine the likely response of a cancer to a specific type of treatment. Now, what the factors relating to tumor biology, which means, talk about ER expression, HER2 expression, the proliferation induction, all these are factors which relate to tumor biology. These are both prognostic and predictive factors, whereas factors related to tumor extent, that is the size, the lymph node metastasis, the distant metastasis, all these are primarily prognostic factors. Now, the prognostic factors are categorized as major prognostic factors and minor prognostic factors. The major ones are lymph node mets, distant mets, tumor size, locally advanced disease, lymphovascular invasion, inflammatory carcinoma, and these are all the minor prognostic factors. Let's understand these one by one. Lymph node metastasis, a very important major prognostic factor, because if you see, look at this table, if there are no nodes involved, the 10-year survival rate is around 70 to 80%. If around 1 to 3 nodes are involved, 35 to 40% 10-year survival, and this reduces to 10 to 15% when there are more than 10 nodes involved. So it's very important to note how many lymph nodes are involved in the breast carcinoma. Second one is distant metastasis. I mean, when the tumor has spread beyond the lymph nodes into the various organs, that means the cure is very unlikely. Coming to the tumor size is also important, because size indicates or predicts the survival rates. If the tumor size is less than 1 centimeter, 10-year survival is more than 90%, and it drops to 77% when it is more than 2 centimeters. Locally advanced disease, which means, when the locally advanced disease means, skin ulceration, underlying infiltration into the chest tissue, it is difficult to control these locally advanced diseases. Lymphovascular invasion, again, it's a poor prognostic indicator. In spite of lymph nodes being negative, if you find a lymphovascular invasion, that means tumor cells within the lymphovascular spaces while examining your breast tumor, so that indicates a poor prognostic indicator, poor prognosis, because these patients might come with recurrence later. The next one is inflammatory carcinoma, another important entity which you need to understand. Inflammatory carcinoma. What is this? This is because of extensive invasion of dermal lymphovascular channels, where the patients present as breast erythema, swelling, and skin thickening. A very classical PUD orange is seen in these carcinomas, inflammatory carcinomas, where the underlying carcinoma is usually diffusely infiltrative. They do not form a palpable mass lesion. Okay, extremely poor outcome, and the 3-year survival rate is around just 3 to 10% in inflammatory carcinoma. These are all the major prognostic factors. Now, moving on to the minor prognostic factors. First one is histologic grade. Higher the grade, poorer the prognosis. The high grade tumors fare very poor. Expression of ER, PR, and HER2. Okay, the survival rates of breast cancer patients is high when they are positive for ER and PR, because they are very responsive for hormonal treatment, right? When all the three are negative, it is difficult to treat these patients. Proliferative rate. Higher the proliferation, poorer the prognosis. Response to neoadjuvant chemotherapy. Before surgery, they are subjected to neoadjuvant chemotherapy. If the patients are responsive, if the tumor is responsive, then it has a better prognosis. That's all. Now, moving on to the last one is the gene expression profiling. What you do here, you actually quantify the mRNA levels in the breast cancer cells. How is this useful here? We try to identify the patients with slow growing tumors, which are anti-estrogen responsive cancers. Through these gene profiling, gene expression profiling, if you can identify these patients, we can easily treat them by giving anti-estrogens, right? So that means that the patients are spared the toxicity of chemotherapy. That's why it's important to note the gene expression profiling wherever feasible. Now, how do you treat breast carcinoma? The main goals of treating breast carcinoma is two. One is to control the local disease, and two, to prolong the survival by treating the known or potential metastatic disease. Now, how do you control the local disease? If possible, in a good setup, the patient can be considered for breast conservative surgery and radiotherapy. However, most often the patients undergo mastectomies. That's how you control the local disease. How do you prolong survival by treating the known or potential metastatic disease? Just by systemic therapy. Now, what do you mean by systemic therapy? You give endocrine therapy in the form of hormonal treatment like anti-estrogens, chemotherapy, if they are not hormonally responsive, and targeted therapy. Like for example, if you know that these are HER2 positive, you can give anti-HER2 or Herceptin. So that's how targeted therapy is being utilized in breast carcinomas. So all these are treatment modalities for breast carcinomas. So we studied in detail about the gross microscopy, the clinical features of all types of carcinoma, invasive duct carcinoma, the special types of breast carcinoma. We discussed about the spread of breast carcinoma, looked into various prognostic factors, and a bit about treatment of breast carcinoma. If you have liked this video, hit the like button, do comment, don't forget to subscribe. Please do share if you find this video useful. Thank you.